Welcome back to Module 1, Introduction to Epidemiology. In Part 2 of this module, we're going to talk about the profile of the practice of epidemiology. In this, we're going to be delving deeper into epidemiology. So let's begin with a discussion on the elements and applications of epidemiology. The learning objectives for Module 1, Part 2 are to define epidemiology, including the important terms and elements in epidemiology. We're also going to examine the epidemiologic approach and review the history of epidemiology. During this, we're going to discuss numerous different examples of epidemiology in practice. So throughout the centuries where there have been health problems, there has always been an effort to identify the cause of those health problems. This effort is the basis of the public health specialty of epidemiology. Epidemiology is the study of the distribution and the determinants of states or events in specified populations, and the further application of this study to the control of health problems. The purposes of epidemiology are to A. Study risk associated with exposures, B. Identify and control epidemics, and C. Monitor population rates of disease and exposure. In the following two slides, you're going to see many different terms that are important in epidemiology. I would ask you to review these on your own, review the definitions that are also in your book, and understand these terms. These are terms that may appear in the practice problems and certainly on the test in the future. There are three key elements that epidemiologists consider when they investigate the distribution of disease and exposure. These are person, place, and time. Person characteristics include age, sex, and race or ethnicity. Place can be described by geographic location, proximity to potential exposure, and clustering. These place descriptions can help epidemiologists to determine whether an outbreak is occurring and whether it's an epidemic or a pandemic. The time element can be date or time of exposure or onset of illness, seasonality of infectious diseases, and identifying endemic versus epidemic disease rates. The epidemiological approach takes many things into account. The first is that the disease does not develop at random, and therefore epidemiology seeks to uncover the risk factors and/or the cause of the disease. The epidemiological approach also includes studying people in natural environments. It observes patterns of exposure and disease in nature, as opposed to in laboratory experiments. Again, I can't reiterate enough that the epidemiological approach focuses on populations, and therefore it looks at characteristics of populations who are affected rather than specific individuals, although that does come into play. Also, epidemiology is very interdisciplinary. It includes biostatisticians, laboratory and clinical scientists, and social and behavioral scientists. Let's look at some examples now. So Legionnaire's disease was first recognized as a distinct entity during an epidemic of pneumonia that occurred in Philadelphia in the summer of 1976. About 4,000 members of the Pennsylvania State American Legion, which is an organization of former military veterans, met in July for their annual meeting in Philadelphia. The convention hotel, the Bellevue Stratford, was considered the best hotel in the city, and it was a frequent convention site and the hotel where visiting dignitaries stayed. In the end of the epidemic, the total number of Legionnaire's disease cases was 182, and there were many deaths. Both convention delegates and non-Legionnaires were affected by the disease, including some who had actually never entered the convention hotel. In fact, some members of a marching band and people who watched the parade outside the hotel became ill. One dramatic example is that of a marching band bus driver who became ill and died of the disease. During the epidemic, there was great public concern and fear arose. In fact, the public did not even attend the funerals of some of those who died because of concern over getting the disease from the corpses. And even before the public investigations had been completed, the Bellevue Stratford had hotel guests canceling their reservations, and the hotel was in fact left empty. Epidemiological studies concluded that the focus of the disease was in fact the hotel, and that both American Legionnaires and non-convention delegates had acquired the disease. At that time, the disease was considered to most probably be spread by the airborne route. However, it took a while for the cause of the epidemic pneumonia to be determined, in fact until December 1976, some 5 months after the outbreak. During that time, tests for almost all known types of respiratory infections were negative, as well as all the toxicological studies. It's now known that Legionnaire's disease is transmitted by the inhalation of aerosolized water and or soil contaminated with Legionella bacteria. It's not actually airborne, and Legionnaire's disease is not transmitted from person to person. However, Legionella does thrive in aquatic systems where it is established within the amoeba in a symbiotic relationship. In the built environment, central air conditioning systems in office buildings, in hotels, and hospitals are sources of contaminated water. Other places it can dwell include cooling towers used in industrial cooling systems, evaporative coolers, nebulizers, humidifiers, whirlpool spas, water heating systems, showers, windshield washers, fountains, room air humidifiers, ice-making machines, and misting systems that are typically found in grocery store produce sections. The disease may also be transmitted from contaminated aerosols generated in hot tubs if the disinfection and maintenance program is not followed rigorously. Freshwater ponds, creeks, and ornamental fountains are also potential sources of Legionella. The disease is particularly associated with hotels, as we saw in this example, and also in hospitals, cruise ships, and fountains with complex potable water systems. Respiratory care devices such as humidifiers and nebulizers that use contaminated tap water may contain Legionella species, so using sterile water in these devices is very important. Legionella bacteria can survive in water as intracellular parasites of water-dwelling amoeba. Amoeba are often part of the biofilms in water systems, and once Legionella and infected amoeba are protected within a biofilm, they're particularly difficult to destroy. Our second example occurred 20 years ago on June 5th in 1981, when an MMWR published a report of 5 cases of pneumocystis carinii, pneumonia, which is called PCP, among previously healthy young men in the Los Angeles area. All of the men were described as homosexuals. 2 had died. Local clinicians in the Epidemic Intelligence Service officer stationed at the Los Angeles County Department of Public Health prepared the report and submitted it for MMWR publication. Before publication, the MMWR editorial staff had sent the submission to CDC experts in parasitic and sexually transmitted disease programs. The editorial note that accompanied the published report stated that the case histories suggested a cellular immune dysfunction related to a common exposure, and possibly a disease acquired through sexual contact. This report in particular prompted additional case reports from New York City, San Francisco, and other cities around the U.S. At about the same time, the CDC's Investigation Drug Unit, the sole distributor of pentamidine, which is the therapy for PCP, began to receive requests for the drug from physicians also to treat young men. In June 1981, the CDC developed an investigative team to identify the risk factors and to develop a case definition for national surveillance. Within 18 months, epidemiologists conducted studies and prepared MMWR reports that identified all of the major risk factors for what was now called acquired immunodeficiency syndrome, or AIDS. In March 1983, the CDC issued recommendations for prevention of sexual, drug-related, and occupational transmission, which was based on these early epidemiological studies. traditional model of infectious disease causation is known as the epidemiologic triangle. The triad consists of an external agent, a host, and an environment in which the host and the agent are brought together, which causes the disease to occur in the host. A vector is an organism which transmits infection by conveying the pathogen from one host to another without causing the disease itself, and that may be part of the infectious process as well. A classic example of a vector is the Anopheles mosquito. As the mosquito ingests blood from an infected host, it picks up the parasite Plasmodium. The Plasmodium are harmless to the mosquito. However, after being stored in the salivary glands and then injected into the next human upon which the mosquito feeds, the Plasmodium can cause malaria in the infected human. Thus, the Anopheles mosquito serves as the vector for malaria. Another familiar example of a vector are ticks of the genus Ixodes, which can be vectors for Lyme disease. In the traditional epidemiologic triad model, transmission occurs when the agent leaves its reservoir or host through a portal of exit, is conveyed by a mode of transmission to enter through an appropriate portal of entry to infect a susceptible host. Transmission may be direct contact, host to host, droplet spread from one host to another, or indirect, which is the transfer of an infectious agent from a reservoir to a susceptible host by suspended air particles, inanimate objects like vehicles or fomites, and animate intermediaries like vectors. So can the epidemiological triad be applied to diseases that are not infectious? Consider a smoking-related disease. If smoking, or more specifically the carcinogen in the smoke of a cigarette, causes the disease, those who manufacture, sell, and distribute the cigarettes are like vectors. They bring together the disease-causing agent and the susceptible host. You can actually diagram an epidemiological triad including this, and this will indicate potential interventions to reduce disease in the population. In this example, clean indoor air legislation, which would advertise potential harm from smoking, or establishing workplace smoking cessation programs could change the environment and therefore reduce the exposure of the susceptible host to the agent of cigarette smoke. Conversely, increased advertising from cigarette manufacturers or increased number of vendors, which in this case we're suggesting are vectors, would increase the exposure of the host to the agent or cigarette smoke. So using this example, epidemics arise when the host, the agent, and the environmental factors are not in balance. There are many things that can lead to this. There can be a new agent, there can be a change in an existing agent, like an increase in infectivity, pathogenicity, or virulence. There can be a change in the number of susceptible hosts in the population. This can have to do with vaccinations and vaccination strategies. And there also can be environmental changes that may affect the transmission of the agent or even growth of the agent. So now we're going to change gears and talk about the history of epidemiology. There are many different pioneers of epidemiology, and these are listed in your book, and I encourage you to read both the book and the assigned CDC supplemental reading. One of these individuals, Hippocrates, attempted to explain disease occurrence from a rational rather than a supernatural viewpoint. Supernatural viewpoints predated him quite a bit. He wrote an essay entitled On Airs, Waters, and Places, and in this essay, Hippocrates suggested that environmental and host factors, such as behaviors, might influence the development of disease. Another early contributor to epidemiology was John Graunt, a London haberdasher and a councilman who published a landmark analysis of mortality data in 1662. This publication was the first to quantify patterns of birth, death, and disease occurrence, noting the disparities particularly between males and females, the high infant mortality, and urban and rural differences, as well as seasonal variations. In the 1800s, William Farr built upon Graunt's work by systemically collecting and analyzing Britain's mortality statistics. Farr, considered the father of modern vital statistics and surveillance, developed many of the basic practices used today in vital statistics and in disease classification. He concentrated his efforts on collecting vital statistics, assembling and evaluating those data, and reporting to responsible health authorities and to the general public. In the mid-1800s, an anesthesiologist named John Snow was conducting a series of investigations in London that warrant his being considered the father of field epidemiology. 20 years before the development of the microscope, Snow conducted studies of cholera outbreaks both to discover the cause of the disease and to prevent its reoccurrence. His work illustrates the classic sequence from descriptive epidemiology to hypothesis generation to hypothesis testing, which is analytic epidemiology, and then furthermore to application. Unlike the Jon Snow of Game of Thrones, this Jon Snow actually knew quite a bit. So let's look at a simplified summary of how the outbreak and the corresponding investigation transpired. During the month of August in 1854, Dr. Snow noticed low-level transmission of cholera in Golden Square area of London. However, during the night of August 31st and through the day of September 1st, there was a marked increase in the number of cases and deaths. Dr. Snow approached the General Registrar's office and obtained the mortality reports for the week ending September 2nd. From these reports, he noticed that there were 79 deaths occurring on the 1st or the 2nd of September. When mapped, 69 of the 79 persons who died, or 87%, lived close to the Broad Street pump. And they lived closer to the Broad Street pump than to any other public pump. From September 3rd through September 5th, Dr. Snow analyzed the water and found varying amounts of organic matter and on some occasions small white particles that were visible to the naked eye. This was enough to convince him that the pump was the source of the outbreak. On September 7th, he presented his evidence to the Board of Guardians, and although many did not believe his arguments, the following day the pump handle was removed. Over the weeks that followed, Dr. Snow put together a list of cases with the date of onset of illness. The list represented the person, time, and place elements of the triad. Here is the beginning of Dr. Snow's aggregated case list, showing the low level of transmission occurring in August, and then the sharp increase in cases beginning in September. From this table, you can see that by the time Dr. Snow approached the Board of Guardians on September 7th to remove the pump handle, the epidemic had already peaked and was declining in severity. Often, by the time an outbreak is recognized and basic epidemiological information is collected, an outbreak is beginning to diminish. However, this is often only seen retrospectively, and Dr. Snow acted on the information he had in the hopes of preventing further transmission. John Snow also generated a map of where the cases resided in order to obtain a more thorough understanding of the outbreak. In this map, the Broad Street pump is located at the tip of the red arrow, and the distribution of cases around the pump is shown by the stacked black bars. Each bar indicates a fatal case. In modern epidemiological practice, this type of case plotting is referred to as a spot map and is often done with programs like ArcGIS. And in the person, place, and time triad, this represents the place. In conclusion, Dr. Snow's investigation and subsequent action demonstrated the basics of public health and epidemiology. Dr. Snow used information about person, place, and time to help identify the source of infection so that he could take action. He's credited with performing one of the best epidemiological investigations during a time when the science of epidemiology was only beginning to develop. His investigations not only had implications for the science of epidemiology, but also in reshaping the scientific views of what caused disease and how it is spread. Epidemiology was further pushed forward when the principles of bacteriology were discovered. Pasteur conducted experiments that indicated that the germ theory was in fact true in the late 1860s. And then Koch, who took Pasteur's work further, developed the 4 basic principles of bacteriology in 1882. This is further elaborated in your book. In the mid and late 1800s, epidemiological methods began to be applied to the investigation of disease occurrence. At that time, most investigators focused on acute infectious diseases. However, in the late 1930s and 1940s, epidemiologists extended their methods to non-infectious diseases. In the period since World War II, there has been an explosion in the development of research methods and the theoretical underpinnings of epidemiology. Epidemiology has been applied to the entire range of health-related outcomes, behaviors, and even knowledge and attitudes. The studies by Dahl and Hill linking lung cancer to smoking, and the study of cardiovascular disease among residents of Framingham, Massachusetts, are 2 examples of how pioneering researchers have applied epidemiologic methods to chronic disease since World War II. During the 1960s and the early 1970s, health workers applied epidemiologic methods to eradicate naturally occurring smallpox worldwide, and we'll discuss this later in this slide set. This was an achievement in applied epidemiology, and this was an achievement of unprecedented proportions. In the 1980s, epidemiology was extended to the studies of injuries and violence. In the 1990s, the related fields of molecular and genetic epidemiology, with an expansion of epidemiology to look at specific pathways, molecules, and genes that influence the risk of developing disease, took root. Meanwhile, infectious diseases continued to challenge epidemiologists as new infectious agents emerged, including Ebola virus, HIV/AIDS, other infectious etiologies were also identified, like Legionella, which we just discussed, SARS, and some of the etiologic agents have been changing, like drug-resistant Mycobacterium tuberculosis and avian influenza. Beginning in the 1990s and accelerating after the terrorist attacks on September 11, 2001, epidemiologists have had to consider not only natural transmission of infectious organisms, but also deliberate the spread through biological warfare and bioterrorism. In fact, epidemiological studies and assumptions and claims are often in the news and the newspapers that we read now. I encourage you to watch the TED Talk by Ben Goldacre on battling bad science, which discusses some of the epidemiological claims we see in the news media, in popular media, and how we can approach those. So now, as promised, let's take a look at an infectious disease that was successfully tackled as the public health infrastructure and science and practice of epidemiology evolved in the United States in the 20th century: smallpox. Smallpox is caused by a virus that is transmitted from human to human via respiratory droplets. They're small droplets which are released when a person, for example, coughs or sneezes, and they generally require close contact with the infected person. Smallpox spreads most readily during the cool, dry winter months, but it can be transmitted in any climate and in any part of the world. The only weapons against the disease are vaccination and patient isolation, where there is no effective treatment. 30% of cases are fatal, and among those who survive, the vast majority have disfiguring pox marks. Vaccination before exposure or within 2 to 3 days after exposure affords almost complete protection against the disease. Vaccination as late as 4 to 5 days after exposure may also protect against death. The World Health Organization was formed on April 7th in 1948 as the United Nations Agency for Health. Its objective was, and continues to be, the attainment of the highest possible level of health by all peoples. The World Health Organization directed the most impressive public health accomplishment in history, the eradication of smallpox. The eradication campaign was initiated in 1967, and 10 years later, in 1977, the last naturally acquired case occurred in Somalia. And the World Health Organization officially declared the world free of smallpox in 1980. However, samples of the virus were retained by the United States and Russia. Because smallpox is rated among the most dangerous of all potential biological weapons, the United States initiated a national campaign in 2003 to vaccinate emergency and medical workers on a voluntary basis against smallpox. The U.S. Department of Health and Human Services now requires that all states be prepared to immunize their entire population within 10 days for smallpox. In the meantime, member states of the World Health Organization continue to debate whether the last stores of smallpox should be permanently destroyed. The issue was discussed at the World Health Assembly meeting in 2014, and it was determined that due to continued interest in research and development involving the variola virus, the destruction of the remaining stocks would be postponed. Epidemiology has been classified as either descriptive or analytic. In general terms, descriptive epidemiology makes use of available data to examine how rates vary according to demographic variables. When the distribution of rates is not uniform according to person, time, and place, the epidemiologist is able not only to define higher risk groups for prevention purposes, but also to generate causal hypotheses based on the classic agent-host environment epidemiological triangle. Hypotheses of associations of suspected risk factor exposures with health outcomes are then assessed in analytic epidemiological studies. A descriptive study is a study aimed at describing the distribution of a disease or other health-related state or event with respect to person, place, and time. Thus, descriptive studies correspond to the distribution aspect of the definition of epidemiology. Descriptive studies often use routinely collected data, such as death certificates, for data from disease registries, and they can help define high-risk groups. For instance, descriptive studies show that African American males have a high prostate cancer incident rate. Descriptive studies can be used to generate hypotheses about disease causation or the determinants of disease, but generally they're not useful for testing hypotheses. For example, examining the geographic distribution of prostate cancer amongst African American males might provide clues about the reason for the high incidence rate in this group. And then using these clues, we can form a hypothesis that will then be tested in an analytical study. An analytic study is a study whose goal is to test a specific etiological hypothesis about a causal relationship between an exposure and a disease. Analytic studies aim to identify disease determinants and correspond to the determinant aspect of the definition of epidemiology. Thus, we would use an analytic study to test the hypothesis that the high prostate cancer incidence rate among African American males is due to low levels of vitamin D, which may be protective against prostate cancer. The distinction between descriptive and analytical studies is not absolute. A given study can serve both descriptive and analytical purposes. There are two main types of analytic studies, which we will delve into further in future lectures, and these include cohort studies and case control studies. Other study types may be descriptive or analytical, depending on their design and purpose. A cross-sectional study is a study of the distribution of exposure and/or disease in a specified population at one point in time. An ecological study, which can fall under both the descriptive and analytical study designs, is a study of the association between an exposure and a disease in which the unit of analysis is a population of groups of people rather than individuals. I would recommend reviewing in the book the basic definitions for cohort study, case control study, cross-sectional study, and ecological study. Again, we will delve into these four types of studies in great detail in future lectures, but it's good to have a strong background before we get into the specific lectures. Now you will be presented with some examples of epidemiologic investigations, including an outbreak of measles, a methemoglobinemia outbreak, and mortality related to a hurricane. As we walk through these examples, look for the key elements of epidemiology, documenting person characteristics, place, and time of occurrence of a disease or health condition. Also, observe the epidemiologic specialties employed and the variety of professions and community groups that are engaged during the practice of epidemiology. First, we will discuss a measles outbreak that took place in Indiana in 2011. Measles is an acute viral illness that can cause severe pneumonia, diarrhea, encephalitis, and even death. It is spread through the air via respiratory droplets, much like the common cold or influenza, and it's one of the most highly communicable infectious diseases. This means that any unvaccinated individual can become infected by being close to or talking to an infected person. Fortunately, due to high vaccination rates in the U.S., measles is not endemic. Typically, there are fewer than 100 cases in the U.S. per year, all of which are related to an imported case of the disease. On June 3, 2011, a U.S. resident, aged 24, who returned home to Indiana after time traveling in Indonesia, exhibited symptoms of measles. The individual was hospitalized in Indiana, mistakenly treated for dengue, and was not isolated. Measles is endemic in Indonesia, meaning that some level of the disease is expected. The rate of measles in Indonesia for this time period was about 9 cases per 100,000 population. On June 20th, 5 family members of this individual exhibited rash illness symptoms, and they came to the attention of the Indiana State Department of Health. And case-finding activities related to this revealed 8 more cases, all but 1 of which were family. The investigators identified an Indonesian strain of measles and proceeded to perform contact investigations for all of the diagnosed individuals. The infectious family members had attended parties. They had attended family gatherings, sport events, and meetings. They had sought health care, which means that they had potentially exposed hundreds of individuals to measles. The public health response to this incident required epidemiologists to work with organizations over 7 counties and included follow-up of exposures at a church, which was approximately 150 people who needed follow-up, a factory, approximately 300 people, and in a bus ridden by school-aged children who had traveled out of state. Healthcare facility exposures included 2 general practice offices, 1 obstetric office, 1 urgent care facility, and 4 hospitals or emergency rooms. Outbreak control measures were instituted, including media releases that informed the local public of the outbreak and the steps to take. Messages with recommendations on how to evaluate patients with fever and rash without exposing others and instructions on testing and reporting procedures were sent statewide to healthcare providers through the Indiana Health Alert Network. For exposed persons without evidence of immunity to measles, the Indiana State Department of Health recommended vaccination of eligible persons within 3 days of exposure, or immunoglobulin administration within 6 days of exposure for patients at high risk for measles complications. In addition, vaccination was recommended for all eligible persons regardless of their exposure history. Recommendations were made to healthcare facilities where exposures might have occurred to exclude potentially exposed healthcare personnel from patient care responsibilities until measles immunity was documented, and to exclude personnel without evidence of immunity for 21 days after their last exposure. Community testing and vaccination clinics were also conducted. For a more contemporary measles outbreak, I have included in your reading an MMWR article on the measles outbreak that occurred in California in December 2014 through on to 2015 at the Disney theme parks in California. Now let's turn to an outbreak of methemoglobinemia that occurred in Iowa in 2003. Methylglobinemia is a change in the hemoglobin molecule of red blood cells that impairs the ability of the red blood cell to carry oxygen. The illness can result in headaches, shortness of breath, nausea, increased heart rate, weakness, fatigue, and cyanosis. Methylglobinemia is most commonly caused by ingestion or inhalation of oxidizing agents, such as nitrates or nitrites. The Public Health Department was tipped off about an outbreak by the media who were calling to find out what was going on at a Saturday afternoon wedding reception. There were approximately 500 people in attendance at the wedding reception, and the attendees began to feel ill shortly after having arrived there. Although it's not uncommon for foodborne outbreaks to take place at catered gatherings, this is an unusual outbreak. In a typical foodborne outbreak, many hours or days will go by before people begin to be ill. But in this case, people were passing out before all the guests even had arrived in the reception. Several attendees were transported by ambulance to local emergency rooms. In all, a total of 83 attendees sought emergency medical care, with 20 being hospitalized. By Saturday evening, public health staff were present at the reception site and at local emergency rooms to investigate. A diagnosis of methylglobinemia was made. After interviewing several attendees, a punch served at the reception was identified as the potential source of the outbreak. Several reception attendees reported that the punch didn't taste very good or that it didn't taste right. Public health epidemiologists determined that the punch at the reception was obtained frozen through a local caterer. The caterer obtained a flavor mix from an out-of-state company to make the punch. The flavor mix was then provided to a local food processing company where sugar and citric acid were added. Then the caterer added water and froze the punch for sale. It turned out that the same lot of punch served at the wedding reception had been served at a baby shower. Upon investigation, baby shower attendees reported that the punch didn't taste good, and 8 out of 13 attendees developed symptoms. Luckily, none of those individuals required emergency care. So samples were taken from the punch that was originally served and from the dry mix. Laboratory testing indicated the presence of sodium nitrate contamination. Sodium nitrate is an oxidizing agent. The amount of sodium nitrate in the mix and the lack of citric acid in the mix suggested that sodium nitrate was accidentally added instead of citric acid. Both sodium nitrate and citric acid are white powders, and both were used at the food processing plant. A mix-up of the two white powders explained the outbreak. The last study that we're going to discuss is based on a natural disaster. In late September 2003, Hurricane Isabel made landfall on the mid-Atlantic coast of the United States. In Virginia, epidemiologists reviewed data from the State Office of Vital Records and Health Statistics and storm assessment and emergency response reports from the governor's office. In the state of Virginia, 32 deaths were associated with this hurricane. Among the deaths, the ages ranged from 7 to 85 years old. 66% were over 45. Most of the deaths were due to drowning, fallen trees, and power outages, while about a third were due to traumatic head injuries. In 28% of the deaths, alcohol or drugs were present. 12 deaths were a direct result of the hurricane, and 20 deaths were indirect. Epidemiologists used criteria set forth by the National Hurricane Center of the National Oceanic and Atmospheric Administration to classify deaths as direct or indirect. For example, a death due to intoxication, someone under the influence of alcohol who fell into water and drowned immediately after the hurricane, would be classified as indirect, whereas a death due to high winds knocking over a tree and killing someone during the storm would be classified as direct. In addition to hurricane-associated mortality, epidemiologists also collect data on disease and injury. In post-hurricane situations, traumatic injury, diarrheal outbreaks due to a compromised water supply, and vector-borne diseases due to increased mosquito breeding puddles in ponds left by the hurricane are all of concern. In addition, epidemiologists collect data on the well-being of population members living in the affected area. After Hurricane Isabel, 210 households were chosen as a representative sample to assess the impact and immediate needs of the population affected by the hurricane. A total of 137, 65% of the households sampled, were without electricity on the date of the survey. Portable electrical generators were used after the hurricane in 64 homes, which is 30%. While this provides electricity for refrigeration and safe cooking practices, generators can also pose risks for carbon monoxide or fire hazards. Other basic service interruptions included 24% without running water and 21%, without working cellular or landline telephone service. A total of 26 households, which is 12%, did not have a 3-day supply of food. 68 households, 32%, had more than minimal damage but were habitable, and 5, which is 2%, were reported uninhabitable. Few hurricane-related injuries or illnesses were reported. 2 households had members who experienced injury as a result of the hurricane, and 10 had a member who experienced hurricane-related illness. A total of 17 households reported a member who required medical care. So in conclusion, let's recap what we've covered in this slide section. We learned that epidemiology is a study of distribution and determinants of states of health or events in specified populations, and it's the application of this study to the control of health problems. We also learned a lot about John Snow and how much he actually did know, how he was a pioneer in the field of epidemiology. His investigation using information about person, place, and time helped identify the source of a cholera outbreak in 19th century England, and it was one of the best epidemiological investigations of his time. His investigations had implications for the science of epidemiology and also reshaped the scientific views of what caused disease and how it spread. In the next section, we'll talk about the tools that epidemiologists use.